So, I have to be honest with you here. Before I picked up the research for today's deep dive, I had a very specific, I guess a very industrial mental image of the human hip.
Industrial is a good way to put it, yeah.
Right, like I pictured a trailer hitch. You know, a smooth metal ball, a solid metal cup, and just a basic hinge. It either works or it breaks, and if it breaks, you get a titanium replacement when you're 70. Just simple mechanics.
That is the default setting for most people. It's the simple hinge theory. And honestly, for a long time, even early medicine kind of treated it that way. It's weight-bearing, it's sturdy, and well, end of story.
Yeah, but reading through this source material, it's a comprehensive radiographic review titled Hip Capsulolabral Complex. That mental image just completely fell apart for me. We aren't talking about a simple hinge at all.
Not even close.
No, we are talking about a high-pressure, vacuum-sealed fluid dynamic system that is honestly kind of terrifying in its complexity.
It really is an engineering marvel. The medical term the authors use in this paper is uniquely constrained.
Uniquely constrained. I love that phrasing. It sounds so intense.
It's a polite way of saying the hip is under an immense amount of pressure and responsibility. It's not just bone resting passively on bone. It is a sealed environment that relies entirely on what we're going to call the soft tissue trinity to function.
The soft tissue trinity.
Right. You have the labrum, the capsule, and the ligamentum teres.
And that is our mission for this deep dive. We are going to decode that trinity for you. We're going to find out why hip pain, especially in younger people, athletes, dancers, is almost never just friction.
Exactly.
We need to talk about things like carpet lesions, hidden cysts, and why your hip might be unstable even if it looks perfectly fine on a standard x-ray.
And to do that, we really have to look at how medical imaging has had to evolve. Because for a long time, we were basically just looking at the bones, ignoring the soft tissue, and telling patients they were fine when they were actually in agony.
So let's just jump right into the first piece of this trinity, the suction seal, also known as the acetabular labrum. Now, looking at the anatomy charts here, visually it just looks like a ring.
Yeah, it's a piece of fibrocartilage that lines the rim of the socket, the acetabulum.
Right, so think of it like a gasket. That's probably the best analogy for the listener.
A gasket is a great way to look at it.
But the research points out something crucial here. It's not just deepening the socket to make the ball fit better physically. Its primary role is actually fluid management.
Exactly. And this is the part that usually blows people's minds. The labrum essentially vacuum seals the femoral head, the ball, into the socket. By creating that seal, it maintains intra-articular hydrostatic pressure.
Which is a very fancy way of saying it's a vacuum.
It is a literal vacuum. It keeps the synovial fluid pressurized inside the central compartment of the joint. And this suction is a massive part of your hip stability.
So it's not just muscles holding your leg arm.
No, it is physics.
Yeah.
If you break that seal, you lose that hydrostatic stability instantly.
So if I tear my labrum, I haven't just ripped a piece of cartilage, I've popped the vacuum seal on the joint itself.
Precisely. The joint becomes micro-unstable. It creates a completely different mechanical environment inside the hip. And because this seal is so critical, when radiologists look for these tears, they have to be incredibly precise about the location. You can't just write down on a chart that it's torn.
Which is where the clock face method comes in. I actually loved this detail in the review because it standardizes what could be absolute chaos. It feels like we are navigating a ship or something.
It's vital for the surgeons to have that map. Imagine you are looking at the side of the hip socket like a clock on a wall.
Okay.
We map it out. So 3 o'clock is the anterior side, the front of your body. 6 o'clock is the bottom marked by the transverse ligament. And 12 o'clock is the superior apex, the very top of the socket.
So if a radiology report says you have a tear from 1 o'clock to 3 o'clock, the surgeon knows immediately, okay, that's anterior superior, that's top front.
Right. It creates a consistent language. And that location tells you a lot about the cause of the injury, which we'll get to. But here is the trap, and the source material spends a lot of time warning doctors about this. The imposters.
The sulci. I have to say this sounded like a sci-fi villain to me. Beware the sulci.
It does sound a bit menacing, doesn't it? A sulcus is basically just a natural cleft or a groove in the labrum. It's a wrinkle. It's a normal variant. And here's the scary statistic. Up to 25% of perfectly healthy people have these grooves.
So let's play that out for a second. You could go into an MRI machine because your hip hurts. The radiologist sees a gap in the labrum, calls it a tear, and you end up getting surgery you didn't even need.
That has happened, absolutely. That is exactly why this paper is so emphatic about distinguishing the two. You have to play detective and look closely at the edges.
How do you tell them apart on a scan?
Well, a tear is traumatic. It's irregular, it extends deep into the substance of the labrum, and it often undercuts the base. It looks like a wound.
Whereas a sulcus looks like it belongs there.
Exactly. It's smooth. It has linear margins, and it usually sits in very specific spots on that clock face, usually the posterior inferior quadrant, so that back bottom area, or anterior superior. If you see a smooth gap there, you should be very, very skeptical about calling it a tear.
But there was one tell in the research that seemed to act like a tiebreaker, the paralabral cyst.
Oh yeah, that is the smoking gun.
The text said that if you see a cyst like a little fluid pocket sitting next to the labrum, the debate is basically over.
Pretty much, yeah. The data shows that if you see a paralabral cyst, there is a 94% chance there is a full thickness labral tear right next to it.
94% is about as good as it gets in medicine. That's Vegas odds right there.
It really is. And the mechanics of why that happens are simple. Synovial fluid is leaking out of the joint through the tear and getting trapped outside, forming a little bubble. So if you see the cyst, you stop wondering if it's a sulcus. You know the seal is broken.
Okay, so we have the seal. We know how to spot a leak. But what breaks it in the first place? This brings us to the second part of our deep dive, the bone shape problem. Or to use the absolute tongue twister, femoroacetabular impingement, FAI.
FAI is arguably the biggest topic in sports medicine regarding the hip right now. It has completely changed how we treat hip pain over the last 20 years.
The concept seems straightforward enough on paper. It's a mechanical mismatch, a square peg in a round hole kind of thing.
Or a round peg that's just a little too big for the hole. We classify FAI into two main types based on which side of the joint has the extra bone. First, you have cam morphology.
Cam, like a camshaft in an engine.
Exactly like that. This is on the femoral side, so the ball. In a perfect hip, the femoral head is a smooth sear. In a cam hip, the head is more like a pistol grip, or it has a distinct bump on the neck. It's aspherical.
So when you flex your hip, like if you pull your knee to your chest, that bump just runs out of room.
It grinds right into the socket. It shears against the cartilage.
And then the other type is pincer.
Right, pincer's on the socket side. It's an over-coverage issue. The acetabulum is either too deep or it hangs over too far. So the neck of the femur hits the rim of the socket prematurely.
And the research mentions a mixed type, which I assume is just the worst of both worlds.
And unfortunately, it's a combination of both, and it's the most common presentation. But I want to go back to that grinding action in cam impingement for a second. The source material describes a specific type of damage that happens here. And the imagery is, well, it's vivid. They call it the carpet lesion.
Yeah, I wrote that down. It's one of those medical terms that makes you wince immediately.
It perfectly describes how the cartilage fails, though. In cam impingement, that bony bump creates shear forces that cause the cartilage to literally delaminate from the bone. It peels away, starting right at the chondrolabral junction.
Like a wall-to-wall carpet lifting off the hardwood floor because you shoved heavy furniture against it.
Exactly. It creates a flap. And identifying that specific pattern on a scan is crucial because it tells the surgeon, hey, this isn't just a random tear, this is structural impingement. If you fix the carpet but don't shave down the bump on the bone, it's just going to peel up again.
Now, to see something that subtle, a little flap of cartilage peeling up inside a fluid-filled joint, you need incredible cameras. The research tracks a really interesting evolution in imaging here from MRA to 3T MRI.
This represents a massive shift in the standard of care. Historically, MRA magnetic resonance arthrography was the gold standard. That involves injecting a contrast dye directly into the hip joint with a large needle right before they run the scan.
Which, as a patient, sounds terrible. I mean, nobody wants a needle driven deep into their hip joint.
It's invasive, it's uncomfortable, and there's a risk of infection, however small. But the dye expands the joint and creeps into those tiny tears, making them show up bright white on the scan. For a long time, it was the only way we could see the detail we needed.
But now we have the 3T.
3 Tesla? Yes. It's a much stronger magnet with significantly higher resolution. The research suggests that for the initial evaluation, a high-quality 3T MRI is now the workhorse. It's completely non-invasive and often just as good at spotting labral tears as the needle injection.
So we basically saved the needle for the really messy cases now.
Exactly. We reserve MRA for postoperative hips, where metal artifacts from previous surgery or scar tissue make things blurry, or for really confusing cases because it is still a bit better at spotting capsular defects.
They also mentioned a processing trick they use called radial reconstruction. This just sounded like pure geometry saving the day.
It really is geometry at work. Think about a standard MRI. It slices the body in straight lines up, down, left, right. But the hip is a curve. It's a sphere. If you slice a sphere with straight lines, you get distortion at the curved edges. We call that partial volume effects.
Which blurs the picture right at the rim where you need to see the labrum.
Right. So radio reconstruction takes the imaging slices perpendicular to the curve of the joint itself. Imagine slicing an orange into wedges from the center instead of cutting straight across it.
Oh, that makes total sense.
It lets you see the true cross-section of the labrum and the cartilage without all that visual noise.
Okay, so we've covered the labrum and the bone shapes that break it. Let's zoom out a bit to the container, the capsule.
The capsule is the envelope that holds the entire joint together. It has longitudinal and circular fibers.
And this isn't just a generic wrapper or a plastic bag. It's reinforced by the big three ligaments. And I have to say, the iliofemoral ligament has the absolute coolest nickname in all of anatomy, the ligament of Bigelow.
The ligament of Bigelow. It sounds like a 19th century strongman at a circus. Step right up and see the mighty Bigelow.
It really does.
And honestly, that fits perfectly because it is the strongest ligament in the human body.
Stronger than the ACL, stronger than the Achilles tendon.
Stronger. It's shaped like an inverted Y sitting right in the front of the hip. Its main job is to limit rotation and stop your hip from extending too far back. It essentially keeps you upright without you having to use muscle energy. When you stand relaxed, you are literally hanging on your ligament of Bigelow.
Then you have the pubofemoral, which stabilizes when you move your leg away, and the ischiofemoral for extension. But inside this capsule, there was another structure that really caught my eye, the Zona orbicularis.
Ah, the Zona orbicularis.
It sounds like a region of space in a sci-fi novel.
Captain, we are entering the Zona orbicularis.
It does have a very cinematic ring to it. Anatomically, it's the circular fibers of the capsule. They form a ring or a tight collar around the narrowest part of the femoral neck.
And the paper noted that for a long time, the medical community just sort of ignored it. We thought it was just there. Historically, it was considered pretty useless, but newer studies show it acts almost like a buttonhole or a Chinese finger trap. It restrains distraction, which is a fancy way of saying it stops the leg bone from being pulled completely out of the socket. It also helps circulate that synovial fluid we talked about earlier.
Now, obviously, this capsule is extremely tough. Bigelow is the strongest ligament we have, but it can fail. The source material brings up trauma, specifically dashboard injuries.
This is high-energy trauma. Think about a bad car crash. You're sitting in the passenger seat, your knees are bent, and upon impact, your knee slams violently into the dashboard. That force drives the femur backward like a battering ram right out the back of the socket.
A posterior dislocation.
Yes. And there's a specific triad of damage that happens there.
Yeah.
If a radiologist sees these three things on a scan, they can almost reconstruct the accident. You see a fracture of the posterior wall of the socket, a disruption of that tough iliofemoral ligament, and hemarthrosis, which is blood filling the joint.
It's gruesome, but it shows just how much violent force it takes to breach that container. But speaking of force and stability, I want to move to what I think is the most interesting narrative in this whole paper. The Cinderella story of the hip.
The Ligamentum teres.
This is section 4 of our deep dive, the Ligamentum teres. For a long time, this was basically considered the appendix of the joint, right?
Worse than the appendix, honestly. At least the appendix might have some hidden immune function. For decades, medical textbooks described the ligamentum teres as an inconsequential vestigial structure, an evolutionary leftover that didn't do anything.
Doctors literally thought this little ligament sitting deep inside the joint was just taking up space.
Right up until the rise of hip arthroscopy. Once we started putting small cameras inside the joint while people were still alive and moving, we noticed something. When people had unexplained chronic hip pain, this useless ligament was often visibly torn or inflamed.
So what does it actually do? Because looking at it, it's tiny.
It's small, but it's a multitasker. It carries blood supply to the femoral head in children. But really fascinatingly in adults, it's a secondary stabilizer. And it's heavily involved in proprioception, which is knowing where your leg is in space, and nociception, which is pain sensing.
So it's a sensor?
It's a sensor and a sling. The paper uses the ball and string model to explain it. Imagine a ball, the femoral head, with a short string attached to the top of it, anchoring it deep into the center of the socket.
Okay, I'm visualizing that.
When you move your leg to the extreme ranges of motion, like deep squatting or doing the splits, or a high kick that string tightens, it acts like a check rein to prevent the ball from popping out or subluxing.
Which explains why injuries to the ligamentum teres are so incredibly common in ballet dancers and martial artists.
Exactly. They are constantly pushing their hips into those extreme ranges where the string is pulled to its absolute limit. If they twist abruptly while in that position, it snaps.
And because it has all those nociceptive pain sensors, a tear there hurts tremendously, even if the rest of the hip is completely fine.
It hurts deep in the groin. It's very often misdiagnosed as a standard groin strain. But now with that high-res 3T MRI, we can actually look for thickening or discontinuity in that little ligament, and we finally have an answer for those patients.
So we've diagnosed the problem, we've found the tear in the seal, the bump on the bone, or the broken string. What do we actually do about it? Let's move into surgery and healing.
Well, broadly speaking, when a surgeon is inside the hip, you have three options for dealing with the tissue: debridement repair or reconstruction.
Debridement is just the cleanup job, right?
Right. If a piece of the labrum is just frayed and flapping around, causing pain, you trim the edges, smooth it out. But you have to be very careful not to remove too much tissue or you break that crucial suction seal we talked about.
So repair is usually better.
Repair is stitching it back to the bone using suture anchors. This is generally preferred now because you preserve the native tissue and restore the seal. But if the tissue is totally destroyed, what we call hypertrophic or macerated, you might have to move to reconstruction, where you use a graft to build a brand new labrum.
But there's a massive controversy mentioned in the text regarding the capsule itself. This felt like a real turning point in surgical philosophy.
You're talking about capsular management. This is huge.
Yeah.
See, to get the camera and the tools into the hip joint to fix the labrum in the first place, you have to cut through that tough capsule. You have to make a hole called a capsulotomy.
Okay, makes sense.
In the early days of hip arthroscopy, many surgeons would do the internal work on the bone or the labrum and then just leave the capsule cut open when they finished.
Wait, they didn't sew it back up?
They figured it would heal on its own. They were actually worried that sewing it would over-tighten the hip and restrict movement.
But we just spent 10 minutes talking about how the capsule and the bigelow ligament are the main stabilizers of the whole joint.
Exactly. And what started happening in those patients was a rise in iatrogenic instability.
Instability caused by the doctor.
Right. Patients would get their labral tear fixed, but their hip would feel loose and painful afterward. The femoral head would slide forward too easily because there was still a gaping hole in the iliofemoral ligament.
So I imagine the pendulum has swung back the other way now.
Hard. Closing the capsule, meticulously suturing it back together, is now the highly recommended best practice to restore that structural stability. It is a delicate balance, though. You risk over-tightening it, but leaving it open is far worse.
Which naturally leads us to the final concept of this deep dive, which honestly feels like the modern frontier of hip knowledge: microinstability.
Microinstability is the most challenging diagnosis in the hip world right now. It is not a full dislocation. Your hip isn't popping entirely out of the socket on the soccer field. It's subtle.
It's a wobble.
It's a wobble. It's a subtle inability to keep the femoral head perfectly centered in the socket during dynamic motion. And that little bit of wobble causes chronic repetitive irritation to the labrum, the capsule, and the cartilage over time.
So who is actually getting this? Is it just the ballet dancers again?
It's very common in people with general hypermobility, think Ehlers-Danlos syndrome, or people who are just naturally very bendy. But we also see it a lot in athletes with repetitive overuse who have slowly stretched out their capsular ligaments over years of training.
And the source implies diagnosing this is an absolute nightmare.
It is very hard. There is no single smoking gun on an MRI for microinstability. You can't just point to a broken bone. You have to look for a constellation of subtle findings. Maybe a little thinning of the capsule, a tear in the ligamentum teres check rein, maybe some anterior labral damage. It's a puzzle.
You essentially have to put the whole soft tissue trinity together to see the big picture.
Exactly. You're looking for a failure of the system, not just a failure of one isolated part.
So bringing this all back around for you listening, we started this deep dive by saying the hip is a simple hinge. I think we've thoroughly debunked that.
Completely debunked. It is a sealed, pressurized, ligament-reinforced precision machine.
And understanding this trinity, the labrum acting as the seal, the capsule acting as the container, and the ligamentum teres acting as the check rein, is key to really understanding why hips hurt.
Absolutely. Because if you have hip pain, it's not always just bone-on-bone arthritis. It could be a failure of that suction seal. It could be a loose capsule from a past injury. It could be a broken check rein. And understanding which part of the trinity is failing is the only way to choose the right path between therapy injections or surgery.
It really highlights why that imaging evolution is so critical. You need the high-res 3T MRI to see the carpet peeling or the paralabral cyst hiding or the ligament thickening.
And it also highlights that we as a medical community are still learning. The fact that things like the Zona Orbicularis and the Ligamentum Teres went from being considered totally useless to absolutely critical in just a few decades of research is very humbling.
That's actually the thought I want to leave everyone with today. We walk around in these bodies every single day, assuming we completely know how they work. But here are parts of us, literal pieces of our anatomy that we confidently wrote off as vestigial leftovers, only to realize they are essential to how we move.
It certainly makes you wonder.
It raises the question, what other useless parts of the human body are we completely ignoring right now just because we haven't been smart enough to figure out what their actual function is?
That is a fascinating question to chew on.
Something for you to think about the next time you go for a run or, attempt the splits. Thanks for joining us for this deep dive into the hip.
Stay curious out there.
We'll catch you next time.